So we heard great talks by Drs. EO on what alcohol use disorder is, and we heard a great talk from Dr. Kim about what happens to your liver when you drink alcohol. Now I'm going to talk about why alcohol use disorder is important to diagnose and to treat. And there are psychosocial interventions that we need to pay attention to. I have no interests, conflicts, or disclosures. So the objectives, the learners will learn how to develop a therapeutic alliance with patients struggling with alcohol use. We're going to discuss non-pharmacologic treatment options. We're going to understand what relapse prevention techniques are in alcohol use. And we're going to understand the importance of interprofessional communication in liver transplantation. I like to read a lot of quotes, and this one from Henry David Thoreau, an American author, said, "It's never too late to give up your prejudices." And we have to take a moment to think about that. Our prejudices, where they come from, why they even exist, so that we can destigmatize the language that we use when we're talking to patients, especially patients with substance use disorders. And note that I'm saying patients with substance use disorders, not an addict or an abuser. Instead, we say a person or a patient with substance use disorder, because it focuses on the respect, dignity, and the primacy of personhood. And we don't like to use the word substance or the phrase substance abuse. Instead, choosing substance use disorder because it avoids implying willful misconduct, and it shifts the emphasis to a chronic disease model. And we don't usually like to use opioid substitution therapy or replacement therapy. We say opioid agonist treatment to avoid implying that we're switching addictions. And a lot of the patients in the community say, I don't want to use a medication that's going to get me addicted to it. And the last two are very, very common. In addition to the first one, like addict, abuser, clean and dirty. We prefer sober or abstinent to avoid value-laden, non-clinical terminology. And instead of dirty or clean urine, we use positive or negative urine drug screen for whatever we're testing for. And this approach will allow us to meet people where they're at, which is essentially the basis behind harm reduction. Now, I'm going to start talking about how we develop a therapeutic alliance, and I wanted to give credit to this fact book that I was using to help guide the presentation. It's a fantastic book written by Daniel Carlat and colleagues that basically focuses on, before you even do anything, when you're meeting a patient who's got alcohol use disorder, you first want to sit down and ensure you have good eye contact when you speak with the patient. You want to avoid staring at your chart and typing away, because it'll communicate that you're making the time to understand versus just dictating orders. And if you need to chart like we all do, you should at least, say, may I chart while we're talking? Just ask permission, or do you mind that I'm charting? And you use empathic statements when you're starting to discuss their alcohol use. For example, you say, I understand why you're struggling. Statements like that sounds very difficult. Or the one we always use in psychiatry, thank you for sharing with me. And you don't just jump in and say, tell me how much booze you've drank last night, or, you start off in saying, tell me a little bit about yourself. I usually always start my therapeutic alliance by asking patients questions about their social history, like who you are, thank you for coming, I was excited to meet you today, I was reviewing your chart, tell me a little bit about yourself. And it immediately warms them up, and they say, oh, I was born and raised in, Detroit, Michigan. I say, oh, I'm from Detroit too. Or they'll say, I'm from Nashville or whatever. And you have a conversation, and then you just kind of lean into why they're there. I saw that you came in for, trouble with alcohol use. Tell me a little bit more about that. After you've already gotten to know them a little bit. Kind of like, developing a rapport. And you want to be very non-threatening and non-judgmental in your approach. For example, would you feel comfortable sharing with me a little bit about your history with alcohol? Or, from what I understand, you've had some struggles with alcohol. Could you share a little bit more about that? And you want to try to understand the positive aspects of the patient's use. You don't want to come off as naive and like, people drink alcohol because it makes them feel good, right? You want to avoid assumptions of negative explanations such as irresponsibility, admonishing patients. And you want to acknowledge that people often use alcohol to improve mood, or they might be bored. I hear that a lot in clinic. Or it enhances their ability to socialize. Maybe it enhances their ability to go out and dance on the dance floor. I know that's something that's very common for people, socially engaging. But you can ask the question more directly. You could say, what is it that you most like about using alcohol? How does alcohol help you? And you want to confront stigma head on instead of just shying around it. For example, basically you're trying to figure out, is there another reason, right? The why. Why is alcohol a problem? You can ask, is there a history of trauma or a mood disorder or chronic pain, by saying, stigma is a big problem. And I want to understand how you feel so I can help you. Once you've gotten a rapport and you've probably walked through some of the medication treatment options, a very important part of the non-medication treatments are psychotherapy. So we have individual or group psychotherapy, and I have two individual therapy examples on the left side of the screen: cognitive behavioral therapy and motivational interviewing. Most of the comments that I've mentioned borrow from the motivational interviewing style, which is a brief, patient-centered approach that aims to help patients identify and resolve ambivalence about changing their drinking patterns. And you do it in a collaborative and a non-judgmental manner. Or CBT, which teaches patients to recognize and avoid situations that provoke alcohol cravings, or teaching strategies to cope with cravings, strategies to avoid the recall of negative consequences and bring about positive thinking. On the right side here, we have a snippet of the groups that we offer at Vanderbilt. You can see multiple different types of groups. We have an alcohol skills recovery group, an open discussion recovery group, we have a trauma recovery skills group, mindfulness-based recovery group, we have a women's focused recovery group, chronic pain support group, and then a group with recovery coaches who have lived experiences. So, highlighting the importance of therapy in our clinic, we want our patients to be involved in at least one group every other week. And there's also mutual self-help programs. So in addition to individual psychotherapy or group psychotherapy, there's mutual self-help. And the essential idea is stopping alcohol use is only the beginning of a journey. And to maintain sobriety, alcohol must be replaced with something just as compelling. And that's what 12 steps represent. And the two key ingredients of 12-step meetings are making positive changes in social networks and learning coping skills to maintain abstinence when you're in a high-risk social situation. And the very, 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 very common 12-step program is Alcoholics Anonymous. And they're free meetings, they're run by volunteers, they're based on the 12-step approach, which is originated by AA. And it's generally considered the most effective treatment for alcohol use disorder, at least for patients who are motivated to participate fully. And that's the key. And there are other groups that are 12-step based called SMART Recovery, or Self-Management and Recovery Training, which are mutual help meetings that are based on CBT and MI techniques, and it kind of removes some of the elements of AA that people may not enjoy. There's a lot of religious overtones in AA, but the steps are the steps, and many, many patients say that the 12-step program saved my life. And this is a little snippet about the 12 steps. And I'm using Alcoholics Anonymous as the example. So steps 1 through 3 are essentially about surrendering. Number 1, you admit that you're powerless over alcohol. Number 2, you accept that a higher power can restore your sanity. Traditional AA refer to God as the higher power, but patients may substitute whatever they find appropriate. Some patients like to use nature as a substitute. And step 3 is deciding to turn your will over to that higher power. Steps 4 through 9 is about confessing. Number 4 is you write out a moral inventory of your behaviors due to alcohol use. Step 5 is you find somebody to confess to. Usually it's a sponsor or a therapist. And the quote here, "We are as sick as our secrets." And that leads into the shame that I'm going to mention momentarily. Step 6 and 7, you prepare yourself mentally to make necessary changes in your life. Step 8, make a list of the people you've harmed. Step 9, you make direct amends to those people. And a lot of patients that I've taken care of, they stop at step 9. They struggle with that one tremendously, because this involves having to walk through some of the shame that they may have harmed other people. And then when this comes up, we would love for them to be participating in individual or group psychotherapy, because return to use or relapse is a high risk at step 9. And then steps 10 through 12, maintaining. Number 10, taking a daily personal inventory. For example, taking the time at the start or end of each day to reflect on your daily behavior. And step 11, engaging in daily prayer or meditation to pray for inner strength to maintain sobriety. The serenity prayer is a very common one. And step 12, helping others, becoming an AA sponsor or helping in other ways, like the recovery coaches we have in our clinics have chosen to make a career out of helping others through recovery coaching. And just a comment about Al-Anon and Al-Ateen. Al-Anon was founded in 1951 as a mutual support group for people whose lives are affected by someone else's alcohol use disorder. And the name is from Alcoholics Anonymous. So this is geared towards families. And including family meetings and treatment of alcohol use disorder is extremely important, because it's the community or the connection that they need. It's not just the patient who suffers or the patient who struggles, it's the people around them. Al-Ateen was founded in 1957 to help target teenage relatives and friends of people who have alcohol use disorder. And like other 12-step programs, these are non-professional, peer-run fellowships with meetings led by longtime members. Another psychosocial treatment option is clinic-based treatment, such as IOP, or Intensive Outpatient Program. And on the right side, I have an example of the pamphlet that is at Vanderbilt. This program is generally provided in a format of 9 to 12 hours per week, spread over 3 or 4 days. And components include individual sessions, group sessions, psychoeducational sessions, and a strong encouragement to also attend 12-step programs outside of IOP. And part of the Addiction Psychiatry and Addiction Medicine Fellowship at Vanderbilt, Drs. E and I get to participate in IOP by leading groups, so we can see firsthand. And some of the attendings that we work with also encourage us and are interested in going with us to an AA meeting or one of the 12-step meetings to give us exposure to how they work. And some studies have shown that There are different intensities of IOP that were compared to a standard treatment, such as maybe 4 to 6 hours per week of therapy. And it showed that both programs were equally effective. This implies that as long as patients are participating in some significant therapeutic treatment, they are likely to improve, which means they're looking for a connection. So naltrexone, acamprosate, disulfiram, etc., are not silver bullets. This is a great TED Talk by a reporter named Johan Hari, who said, it's a 14-minute TED Talk, that the opposite of addiction is not sobriety, it's human connection. And these humans who are looking for a connection will struggle, and they might return to use or relapse. And notice I say return to use because relapse might have some stigmatizing connotation. And since return to use is the rule rather than the exception, we must make relapse prevention an integral part of treating AUD. So we start the conversation with patients. For example, do you see any barriers that would be a problem to your recovery? Or is there something that could derail your abstinence? You encourage planning ahead by asking, what are some situations where you will be tempted to use? And you teach refusal skills, strategies for successfully turning down opportunities to drink. And this is what I hear is very common for patients. If they're looking for a connection and they're going out to dinner with families and friends, like the dinner that's here tonight, and we are offering non-alcoholic beverages in honor of the talk, but if there were alcoholic beverages, what do you say to friends who are saying, hey, have a beer, come over, and just chill, right? You can simply say, oh, no, thank you. Or you can say, I find I don't sleep well when I have a drink at night. Or you can say, I have to stay clear-headed because I have some work I need to do. When you hear some of these phrases, you might think it's promoting stigma or shame. But sometimes people don't want to say, hey, I struggle with alcohol use disorder. Or if somebody offers you salt on your salad, hey, I have hypertension. It's nobody's business what you're dealing with inside, right? Or if it's somebody you feel safe with to share, maybe you choose in that moment to share, but you don't have to. But you're helping the patient with a list of alternative activities to drinking. You're suggesting non-alcoholic beverages. You're suggesting comments and phrases for them to say so that in the moment they're not being forced to think on their feet and return to use. The rate of relapse is 40 to 80%. It's a big number. I've learned through my training the HALT mnemonic to help patients realize that, well, maybe it's not social situations. Maybe I'm hungry, maybe I'm angry, maybe I'm lonely, maybe I'm tired. Acknowledging the emotional or physical states that can lead to return to use. And you go over the most common causes of relapse or return to use, along with suggestions to manage. For example, if patients are using alcohol to self-medicate, ask them to reach out for help. If they're tempted by the triggers around them, ask them to avoid situations that cause these triggers. Some patients are overconfident. They say, well, I can have a beer or two or drink moderately. But controlled drinking often leads to relapse. Some patients that are bored and like to drink, well, you offer hobbies, activities with non-drinking friends. And these are conversations you can have with patients if you have developed a good therapeutic alliance. And then, of course, connection. Getting involved in AA or other mutual help groups or leadership roles will help patients have alternatives to drinking. We also recommend journaling to help identify the situations that lead to return to use. I say, write in your journal. Bring it with you next time you come to clinic. Let's see what's on your mind. Maybe that clinic visit, I just refill their naltrexone and spend my 15 to 30 minutes talking about what's in their journal. I don't need to talk about naltrexone for 30 minutes. They'd probably eyes glaze over and stop listening. And then you encourage the patient to start and end each day by committing to sobriety. For example, I'll tell patients, start the day by reading something focused on your recovery, and then mindfully plan your day. Or end the day by confirming you are following your recovery plan, giving yourself positive affirmations and validation, self-validation. And again, the rate of relapse is 40 to 80%. So if the patient comes to clinic or a family member comes to you and they say, you know, Dr. Raffoul, I had a slip up or I drank. Well, I say the rate of relapse is 40 to 80%. So, you know, those are the facts. They might like to hear the data. Or you can say, I'm glad that you reached out. Thank you for sharing with me. The goal is to provide a safe space for them. You don't want to shame them by saying, how the hell did you do this? What's going on? I'm so disappointed, right? Because it's going to shame them and they're going to look like Van Gogh's painting. You know, just inside they're going to feel like they're wanting to crawl into their own shadow. And then I've mentioned some of these other recovery plans, like creating a schedule of activities, AA meetings, regular check-ins with your providers for med management, regular check-ins with therapy, individual or group, regular check-ins with sponsors, regular involvement in non-drinking activities. All these things are almost a must-have for patients to not use alcohol. And then the part of the physicians or the providers. What can we do, right? Interprofessional psychosocial communication in liver transplantation is an art. And what do I mean by that? Well, we've defined alcohol use disorder. We've defined what it is in great detail, what could it do to your liver, and what's going to happen if you need a liver transplant. It's a very costly, time-intensive affair that maybe some people never get, but then once they do get it, what can we do? This is a great article on the bottom right by Winder et al. That was published last year in Transplantation Reviews that highlights that psychosocial phenomena remain some of the most challenging matters that liver transplantation teams encounter. Patients are often most focused on biomedical aspects of their treatment and transplant course rather than the subtle psychosocial factors which must be addressed alongside the medical and surgical problems. For example, this means that the patients may not accept the team's recommendations for psychiatric and substance use disorder treatment despite their primary role in treating liver disease and promoting successful transplant. The patient might not be like all in, essentially. My liver is dead or dying, I need a new liver. They get a new liver, but they're not understanding the why. They just are buying into the what. And alcohol-related liver disease is the archetype of these challenges. So we need a crucial, actionable, and rarely discussed factor in creating this interface between liver patients and psychiatric and substance use specialists. Because talking to each other in addition to talking to patients ensures abstinence. And this is basically what it looks like. This figure shows that there are 3 crucial interprofessional psychosocial communication time points during the transplantation for alcohol-related liver disease. You see at the bottom, the arrow pointing to the right, there's an initial evaluation, an initial psychosocial concern, and need for a psychiatric evaluation. It's part of a lot of the liver transplant protocols, if not all liver transplant protocols. And you get a psychiatric evaluation. The specialist will make treatment recommendations. Patients are listed. Patients get a transplant. And then the psychiatrists disappear, like we never see them again. Or we make sure that alcohol use and ongoing psychiatric treatment is a requirement, not just on the side of the providers, but on the side of the patient. They believe that this is something that they need to stay healthy. And there's a lot of reasons why the patients may not be all in. This figure basically just highlights the potential sources of ineffective communication in hepatology and liver transplantation. Sometimes we may minimize the importance of psychosocial factors. We might defer or avoid talking to them about them directly. We might be a little bit cynical or place blame if patients return to use. We might get too enmeshed in the patient's lives and lose objectivity. There might be some apathy or passivity. There might be risky or confusing or inaccurate information. An example of that would be if a patient asks, "Can I have a drink?" and somebody might say to them, part of the care team, "There's nothing really wrong with just a drink on your birthday or at New Year's." But that will underscore that they're not taking the message of alcohol use disorder seriously, and the patients will use that little sliver as an opportunity to kind of return to use. That's how fragile their recovery and abstinence is. And there's sometimes unhelpful responses to patient psychopathology, meaning some of these patients may be challenging, and not everyone may have the skill set to be able to navigate the different psychiatric co-occurring illnesses that patients may have, including personality disorders, because alcohol use causes changes in people's ability to think and cope, or vice versa. So in conclusion, there are many approaches to treating alcohol use disorder, and the initial approach for any given patient will vary, depending on the severity of their use, their experience with treatment, the existence of concurrent illness, psychiatric illnesses, etc. And for somebody who has a mild alcohol use disorder, as Dr. Eo had listed some of the criteria, there's 11 criteria. If they meet 2 or 3 criteria, they have mild use disorder, we can be curious and be patient and just kind of like, what's going on with your alcohol use? Maybe use some of the screening instruments that Dr. Eo had mentioned. We can offer self-help resources if we're concerned. Refer them to research info from the National Institute on Alcohol Abuse and Alcoholism, which again, you see the name of the National Institute of Alcohol Abuse. There's legislation that's going to change it to alcohol use disorders or alcohol and addiction. And then there's bibliotherapy. For example, 2 books that are very good, Alcohol Lied to Me by Craig Beck, or The Happiness Trap by Russ Harris and Stephen Hayes. If we have moderate use disorder, we usually recommend psychotherapy, Alcoholics Anonymous, or 12-step groups, and start to consider medication treatment. But if somebody comes in with severe alcohol use disorder, for example, the patient's life revolves around drinking, they have had significant health and legal consequences, found it difficult to hold a job, maintain relationships, then they may likely need inpatient detoxification and or inpatient rehabilitation, like residential treatment, aka rehab. They will need intensive outpatient program. They might need medication, psychotherapy, group, sober living. Typically, I like to give all of the above. I try to encourage the patient to stop using, go to residential treatment, come out and go into an intensive outpatient program, then follow up in clinic, weekly visits with medication, individual psychotherapy, go to groups in our clinic, go to AA meetings, and if their environment is a trigger for them, encourage sober living. Like, I do all of them, and I talk about all of them every time I see them in clinic, and encourage all of them if they have severe alcohol use disorder and or they're in a liver transplant situation. And that's it. Thank you.